We do have some time for questions, and I'm sure that there will be some questions from the floor for Dr. Mattison.
What do you believe led your government, or should we say your NIH itself, to put that effort into pregnant women? Was there any, because with the pediatrics we know the rules and all that, but what led them to move with this, which is the first in the world?
I think there were. Is this working? Yes. Okay. I think that there were several stimuli for it, Giddy. I think that the strongest was practicing OBGYNs who were frustrated with the issues around therapeutics, not having data on dosing, efficacy, and safety. And they continued to push for improved knowledge. And that was, I mean, quite frankly, I think it's an issue of advocacy. The reason that pediatrics is a decade or more ahead of obstetrics in terms of therapeutics, I think in every place that you look around the world, is because pediatricians have been stronger advocates for improved therapeutics and have worked aggressively to improve our knowledge. That's beginning to take place in obstetrics. I think it needs to happen more, though.
Yeah. Don, I mean, this is a very interesting overview, but there are a couple of things you didn't mention. One is the whole issue of low birth weight, prematurity. I realize that's not entirely a pharmacologic issue. It may turn out to be largely a genetic issue, but how does that relate to what you're describing? And I guess part of that as well would be the existing maternal fetal medicine network, which how does that relate to the obstetrical pharmacology program?
Those are really good questions, Stuart. The issue of prematurity is a very pressing issue in the United States, and there is data from one clinical study that's been done by the Maternal Fetal Medicine Network, suggesting that a progesterone analog, 17-alpha-hydroxyprogesterone caproate, can decrease the risk of preterm delivery in women who have previously had a preterm delivery. And from my perspective, the thing that I found interesting about that data is that the clinical efficacy studies for that drug were designed and implemented with no knowledge of disposition, metabolism, pharmacokinetics, mechanism of action of that particular drug. Now, this litany of things that we think of as necessary for designing a clinical trial are also encountered, as you know, in pediatrics. Drugs get studied for efficacy or safety without thinking about what is the disposition of that drug? What are the pharmacokinetics? What are the potential mechanisms of action? Is it metabolized? What role do the metabolites play? So the second drug that our OB Pharmacology Network has decided to investigate in a very detailed way is the 17-alpha-hydroxyprogesterone caproate. So we were in this peculiar situation that the drug appears to be effective, but we're not sure. And what we're trying to do is create a scientific basis for understanding if the drug is or isn't effective, why might it be or might it not be. We're beginning to look, too, at issues in pediatric morbidity and mortality to try to help us think about how do we identify those drugs of highest potential impact for study across the course of pregnancy. So We ultimately will, I think, begin to look at in greater detail the issues that you've mentioned in terms of a public health perspective. We do it in collaboration with the other networks in the U.S., and obviously we're looking for other potential collaborators as well. These are difficult questions. They often can't be answered in terms of small studies. I mean, clearly the pharmacokinetics can, but efficacy and safety often requires a substantially larger group to study.
I wonder if you could just give me a little information about how your group relates to the FDA in the States. I run the Women's Mental Health Program at the University Health Network, and over the last couple of years we've had Health Canada releasing alarmist reports about antidepressants in pregnancy, seeming without reference to the sort of clinical knowledge around and a balance of risk and benefits. And then we have to deal with the fallout from patients who immediately have heart attacks over what they're taking. And, is there any interrelationship between the research you're doing or the knowledge you're accumulating and those kind of things in the States?
We try to maintain very, very close relationships with the FDA. Of the two major studies that we're doing, one with the 17-alpha hydroxyprogesterone caprate and the other with an oral hypoglycemic used for treating gestational diabetes, we have made a promise to the FDA that all of our data will be shared. The caprate study is actually being done under an IND, an investigational new drug approval. We try to be as close as we can. They do have, it's the tension between a regulatory agency and a research agency is very real. We're interested in asking and answering questions. They're interested in trying to understand how better to fulfill their regulatory responsibility. With respect to more interaction across the course of pregnancy, we've actually been talking with them about having diseases in pregnancy declared rare diseases because that actually provides some regulatory benefit for drug companies who engage in research across the course of pregnancy. But it's a constant. There's a constant need for communication and dialogue, and we don't always see eye to eye.
Dr. Mattison, I would like to ask from a practical point of view, how is it that there can be better cooperation between countries, for example, the U.S. and Canada? We all know that many medications are available in the U.S. Far sooner than they are in Canada. And what's your opinion on how there can be a better standardization of those approvals?
I guess that I would see that question as having sort of two parts. One is the issue of increased sort of collaboration for scientific questions, and I'm hoping that the CIHR NIH courses in obstetrical therapeutics and in epidemiology will help drive sort of a standardization of scientific knowledge or approaches across the two countries. And then I think that may potentially influence the way that the two federal regulatory agencies deal with issues. I got to say, the grass is always greener on the other side. I look at what Health Canada does sometimes in therapeutics, and I think, gosh, our FDA is so far behind what's going on here, because I've seen so many things that I think that the FDA has totally screwed up. That I think is handled much more rationally here. And I think, the SSRIs are a good example of an area where I think the U.S. has been way behind both England and Canada in terms of safety questions.
That's very, very reassuring. I'd like to thank you, Dr. Mattison, for your presentation and for your